It's a real privilege for me to introduce my colleague, Dr. ARVIND BHIMARAJ, who completed his residency at Drexel in Philadelphia, followed by cardiology, Cook County in Chicago, and advanced heart failure fellowship training at the Cleveland Clinic. And he's been on staff here more than several years, and really has been key and instrumental in setting up our heart failure disease management program, in addition to significant contributions for our end organ program. And his research focus has been part of monitoring for heart failure and the use of CardioMEMS, and he's positioned nicely to give us an update on remote monitoring.
Thanks, Chair. I think I planted our nurses to woohoo for me. So, in the world where we're trying not to be monitored and security and privacy, I think this is one area where we're actually happy that we're able to monitor our patients. So today, that's my disclosures. I consult for Abbott. We're going to talk about why remote monitoring is important for heart failure, and then maybe review a bit of the kinds of monitoring with a major focus on hemodynamic monitoring. I was telling Jerry as I was putting this talk together, I realized I actually talked about this 2 years ago in our first summit, but there's been major advancements that I felt last year was all we walked away without knowing what to do. So we'll spend some time on remote pulmonary monitoring, and then touch a little, if we have time, on the impedance and opportunity with the ICD diagnostics. The monitoring is not a new idea. 1924, if you notice the date up there, this was a pictorial representation put up by a guy by name Hugo Gernsback, where he devised a way you can actually check the patients at home with a radio transmitter. So if you think about it, from 1925, people have been thinking about the concept of monitoring patients at home. It took all this while for us to have something more substantial, especially focused with heart failure. So why do we have to monitor? And in essence, these are all reasons you can think about. Monitoring to avoid hospital readmission, that's the readmission mantra in the current world. Hospital admissions, or actually are you trying to avoid a decompensation of heart failure, or are we really trying to promote health for these patients who have congestive heart failure? Now, we're not going to talk about remote monitoring in other conditions. The focus will be on heart failure. And what do you want to monitor? Right? When our nurses call the patients and say, hey, Mr. Smith, how are you doing? That's kind of monitoring. That is symptom monitoring. Are you going to monitor weight, blood pressure, heart rate, the rhythm parameters in ICDs, impedance, the respiratory status, ambulatory status? These are all things that are devised into discussions of remote monitoring when you talk about remote monitoring for patients with heart failure. So not going too much into the specifics, but it can be patient-triggered, where the patient has to make efforts to go on a weighing scale, press a button, and the Bluetooth blood pressure gets transmitted or the weight gets transmitted. It can be triggered by an ICD that the patient has, or it is a triggered transmission of hemodynamics like what we have today in the CardioMEMS technology, which we'll talk about. Or it's a healthcare provider monitoring, where the healthcare providers have to call the patient and say, hey, do this, do that, or tell me how you're feeling. That essentially is monitoring also. There are a lot of other devices that are coming in which also are monitoring without anybody triggering. There are people, companies and investigators are devising piezo crystals under the bed. When you lay at night, it monitors your respiratory rate, and if you're breathing a little heavier, it picks it up. So there's a lot of push in this field where monitoring as a concept of promoting health at home has been a focus for a congestive heart failure. But what is the final outcome we're trying to look at here? So there are EP diagnostics, heart rate, blood pressure symptoms, symptom screening. These are all what I classify as non-hemodynamic parameters of monitoring, which essentially lead to the final state of a heart failure exacerbation, which is a volume overload state, which we all think is the crux and a problem for patients getting admitted or not feeling well. So with that keeping in mind, my personal opinion is that hemodynamic parameters and monitoring are here to stay, and that's really the crux of the advantage of monitoring these patients at home by knowing what I call as the gold standard of acute exacerbation. And just to put this out of the way, the non-hemodynamic monitoring have been studied in multiple trials. These are all the list of trials looking at impedance, remote monitoring with ICDs, remote monitoring with telephone support. Essentially, not a big evolution in a positive trial historically. That's the reason why we have not used any of these effectively for remote monitoring of patients. So what do we mean by hemodynamics? So to go over this cartoon quickly, this is the right ventricle, left ventricle. You have the lungs, and then the pressures here is the wedge pressure or the left atrial pressure that we normally measure as a reflection of the left ventricular end diastolic pressure. That's what makes people out of breath if your wedge pressure goes up. Normal is 12, 25 is high. So when you go through a phase of volume overload, you can go from a normal state to what's called as hemodynamic congestion, which means the hemodynamics say you're congested, but that doesn't mean the patient is short of breath, nor does it mean that you have X-ray findings or anything else that suggests patients are volume overloaded. And a good percentage of patients can live in this state, compensated. They then move on to a state of pulmonary congestion, where in the lungs you can find X-ray findings of curly B lines or more vasculatures suggestive of volume overload, which essentially can finally lead to, I think we skipped that, finally lead to clinical congestion, and this time lag can range anywhere from 15 to 30 days. So patients at home compensate, which is good because that's how the body works, but it takes about close to 15 to 30 days for them to feel the symptoms, which is when they get alerted and call us, and then you're too late by the time. What also complicates is picking up fluid in a patient is not that easy. And when you look at the sensitivity of all these signs of JVP, edema, S3, the best is about 50% if you're short of breath, 48% sensitivity if your JVP is high. And the specificity is not bad, but when you're using something to screen at home, you want it to be sensitive so that you pick majority of the people. And the problem also is if you're oversensitive and not specific, and all these people will end up in the ER or call you because you're finding these signs and symptoms. But this is physical exam to remember that volume status, even in the hospital, in the clinic, is not the best. And so we'll go on to the first audience response question. What is the sensitivity of weight gain of 3 pounds in 1 day or 5 pounds in 3 days as a marker of volume overload and hence a predictor of hospitalization in heart failure patients? So kindly answer 86% sensitive, 74%, 22%, or 5%, or I really don't care about weight. But we do beat this down for patients to weigh them on a daily basis. It's a good behavior. I'm not saying that's a bad behavior. But when we're putting so much weight on the fact of weighing themselves, we should know how good it is. So 8% got it right. It's about 22% sensitive when you're having 3 pounds of weight gain in 1 day or 5 pounds in 3 days. Not that remarkable, but that doesn't mean we're going to tell them not to weigh themselves, because that is still an easy, simple way to do. But we have to be mindful that it might not be picking up all the patients that end up coming in with congestive heart failure, acute exacerbation. And this is a reality that has been shown in trials. So there are a couple trials which were acute exacerbation patients who got admitted. In that trials, when people went back and looked, 90% of the patients of heart failure hospitalizations were because of pulmonary congestion, which we know. Majority of the patients come in with shortness of breath. And also the caveat I have to say, most of the discussions here are related to left ventricular dysfunction. We're not talking much about RV dysfunction, which is a whole other animal to discuss. But when these patients at discharge were analyzed, 40% of them had moderate to severe congestion still while they left the hospital. 60% of them, they had only mild congestion. And the 60% of those who had congestion, when they were followed up for 60 days, 41% of those who were previously decompensated, decongested, ended up having severe or partial recongestion. So the volume status is not that easy to control even after you come in with a volume overload. And it was appropriately pointed out in many editorials that it's almost like a post-hospital discharge syndrome. A lot of things change, and you can actually reaccumulate a lot of volume if you don't know about it. So which of the following statements, another audience response question, about a heart failure hospitalization do you agree with the most? 30-day readmission for the heart failure is more important than any heart failure hospitalization. Heart failure hospitalization is no big deal. It's only fluid, and we can easily get it off. I wish my administrators got off my back about this. I don't know why we should care about it. We all make money when we see patients. Why do I care about heart failure hospitalization? I'm sure the answers will come out if you give some wine or alcohol here. Right? Everybody's trying to curtail their... So this is an important thing to remember. 72% of all of you thought 30-day readmission is more important. It's more important because it's been drilled down into our brains because we're talking about 30-day readmission, which is a whole fiscal discussion of health economics, which is important for the nation. So 30-day readmission is bad, but a heart failure hospitalization in general is not good for patients. So if somebody comes in from an outpatient clinic, that is a heart failure hospitalization. That is bad. The readmission might make them, be a worser physiology, but if they come back in because of non-heart failure related situation, they have not much to do in the context of prognosis. So this is a classic slide which reflects that. If a patient gets admitted for the first time in their lifetime of heart failure, there is a 30-day mortality of 12% and 1-year mortality of 34%. And if you keep going up, look at the fourth admission at 1 year, your mortality is almost 50%. This is a rebuttal for certain patients who kind of tell me saying, oh, it's my Christmas time to come in because I ate a lot, I'll get my Lasix, feel better, and go home, because it's not a benign thing to get admitted to the hospital. And that is important for us to remember. Every decompensation you have, you fall off the survival curve. You never regain back. And there's a lot of hypotheses about it, and I won't go into the details, but a heart failure hospitalization is a bad thing. So the next question is, a 56-year-old male, EF 20%, high BMI, obese, was recently hospitalized with decompensation. He's seeing you in clinic. He states that he's been limited with shortness of breath with minimal activities for many years, but has been stable at that stage. He had a right heart cath done during his recent hospitalization, showing a wedge of 30, cardiac output is okay. Which of the following therapies can reduce hospitalizations? Daily remote monitoring with a Bluetooth weighing scale and blood pressure monitor. The first option, plus a virtual avatar nurse who asks the patient about symptoms on an iPad. Remote monitoring of pulmonary diastolic pressure, an LVAD placement, or heart transplant. Wow, it's not moving. Right, so everybody gets this right. Now, you can argue on the severity of the patient, on rehospitalizations with heart transplant, but presuming that, oh, it's coming up. So we have bad believers. Yeah, so the daily monitoring of Bluetooth technology is an interesting thing because if you actually go back and look at all the evidence, none of the trials panned out to show that that reduces hospitalizations as such. And we're going to jump an LVAD placement. If you call somebody end stage to a point that they have all the prognostic errors, maybe that might be a right answer. But the current role of pulmonary diastolic pressure monitoring is what we're going to get into as the mainstay of hemodynamic remote monitoring. So the CardioMEMS system is essentially the only hemodynamic monitoring system that's approved by FDA to reduce hospitalizations. And there are a lot of other technologies that are coming up, but this is what we have right now. So what is it? It's a small sensor that gets implanted in the descending left posterior branch. The patient goes home, and I'll tell you what the technology is. No wires, no batteries. Patient goes home with an electronic system which he or she then uses to press a button and transmit those PA pressures into a Merlin.net system on the website, which is what the ICD diagnostics also go in. And essentially, it's like a remote Swan-Ganz catheter that you're monitoring the PA pressures, which has been shown to reduce hospitalization. So this is where it sits in the descending pulmonary artery. And you see the orientation. It kind of just flops in there with the wings of it. This is a reconstruction from a pig model that we have created for training cardiologists to practice implants. But you can notice that it just sticks to the wall once you deploy it. So the technology, now that I can speak to all these CPs, I'm mathematically challenged. I let my wife calculate the tip when I go to the restaurant, so I can't explain all the specifics. But essentially, it's a pretty picture. But what it is there are capacitors in here, and as the there's a blood flow up here, changes the capacitance and essentially calculates the pressures of the blood flow in the pulmonary artery and transmits it out at the time that you press the button of the receiver. That frequency basically pulls the pressures. So with that technology, the CHAMPION trial essentially was the one that validated this. So the CHAMPION trial, so the sensor is about 2 millimeters thick, 15 millimeters wide, and these are the wings that I call kind of just deploy and then just stick to the PA when you deploy it. So the trial was kind of a smart trial. 550 patients, all of them got the implant. But then they were randomized to the control patients, and the control patients essentially had the sensor, but they never transmitted the pressures, and the physicians, they transmitted the pressures, but they were not revealed to the physicians. So that's kind of the blinded arm. And they followed primary hospitalizations and then PA pressure decline. Of note, the EF of greater than 40% was kind of used in that trial as a preserved ejection fraction, and Imad was talking, the definition of preserved ejection fraction has evolved, but if you reflect this as preserved ejection fraction, EF was not a cutoff, so you could have the old term of diastolic heart failure or systolic heart failure, you could still be in the part of this trial. Essentially what it showed was if you use the PA pressures and monitor them over a period of time, the treatment group, the hospitalizations were much less compared to the control measurements. And there was a 37% relative risk reduction of hospitalization. This has nothing to do with readmissions. It is a heart failure hospitalization that has been shown to be significantly reduced. And of course, the PA pressures came down when you looked at them and tailored it. When you didn't look at them, the control arm all got phone calls by the nurses still. So in my mind, I think that's a little more than what happens in the real world. Unless you tell me that in your practices, nurses are calling every week, it's not feasible for us to do that. In the trial setting, despite that effort, calling and checking on the patients, their PA pressures remained about the same, did not reduce compared to the treatment arm where the PA pressures came down. And essentially, to summarize, the number needed to treat to avoid a hospitalization is probably the lowest for the PA pressure monitoring from the CHAMPION trial. And what this means is if you put it in 4 people, you avoid hospitalizations in 1. And that's the number needed to treat that we always calculate for outcomes. And most of these neurohormonal modulating medications have been devised for mortality benefit. So it makes sense that if you decongest people, their hospitalization rate should come down. And this was replicated in a real-world experience of a 2,000-patient cohort, showing that even in the real world, the PA pressures actually have come down much more dramatically compared to the CHAMPION treatment arm, showing that out of a trial atmosphere, it's actually worked well. There was a recent publication looking at a reduced EF cohort, and in that cohort, there is a signal towards mortality benefit, and it's a sub-analysis, so we can't take it with too much weightage, but there's a trend to suggest that if you decongest the heart, there's probably a mortality benefit. Maybe the neurohormonal modulation gets better, but that's a hypothesis to be proven further. What is also interesting is that this was a cohort of patients with respiratory problems. In this cohort, when you decongested the patients, both your heart failure hospitalizations and respiratory hospitalizations got better. And I think that's the cardiopulmonary interaction that sometimes if you keep the lungs dry in patients with lung problems, they might do better from that standpoint. Now the readmissions, which we all talk about. Actually, this was an analysis showing that the green dots are dots that were part of the CardioMEMS trial. Their readmission ratio at that time was much better than the rest of the hospitals in the nation. I mean, it kind of speaks the same theme that heart failure admission is important. Coming to Jonathan's question earlier about the cost analysis actually shows that you save about close to $7,000 compared to your previous 6-month analysis of expenses. And if you do a 12-month analysis of expenses, you're saving about $11,000 when you look at all the heart failure expenses, including the implant and other charges. A cost effectiveness analysis using a Markov diagram was recently published, and here you'll notice that the QALY is about $44,000. Anything less than $50,000 is considered as very cost effective, and I think we use that in the dialysis realm. And in this study, they show that even if you jack up the price of the CardioMEMS and double it, you'll probably raise this to up to $75,000, still making it an intermediate range, showing that the hospital expenses will be reduced. So to kind of wrap up about CardioMEMS, essentially anybody with class 3 symptoms after optimal medical therapy for at least 3 months after a BIV and 1 hospitalization within the last year currently qualify to get a CardioMEMS sensor to avoid rehospitalization based on the labeling. So lack of time, I'm going to move on with some of this data. But we have an outpatient follow-up protocol that we use. The important part to note is it's not all about fluid, but it actually gives you an eye into the blood pressure and afterload reduction, which is what the trial showed. So you end up increasing individuals with their afterload reduction with nitrates, hydralazine, and I think that's probably what might be driving the mortality benefit if I have to postulate. And you get an alert on your email screen that you can use to set alerts for the patient so that you're not reviewing it regularly. And essentially, this is how the screen looks. I have a case example. I think I'll skip it based on the time. But you look at the PA pressures and use this to adjust and manage your diuretics or afterload reduction. And with this system, I think we've had good success of keeping people out. I'm going to skip these cases. Probably the one thing to reflect here in this case, this was a patient who was listed. If you look at the hospital utilizations here before implant, they were quite significant 3 or 4 times a year. And after the implant, they kind of came down where you're able to modulate things and adjust according to the. So the implant is in the cath lab, Swan-Ganz. You do a PA angiogram and essentially find a PA which has some. It has to be 7 millimeters and less than 30 degrees. But just to show you that it's a relatively simple procedure, and the sensor comes preloaded, and essentially you deploy it over here that you can see the system by just twisting this and pulling it up, and you see the sensor here that got deployed, and you basically calibrate using the system with a Swan-Ganz catheter and give it a particular reference realm for them to go with. So I'm going to wrap up with the fact that thoracic impedance, the concept of impedance, is what has existed in ICDs. I think it's important for individuals to know there's a potential for it. What the defibrillator does, it can measure the impedance of the electrical activity between the lead and the can. And essentially, if your lungs get soggy, the current conducts better. If the lungs are inflated without water and normal air, then the current does not transmit as much. And that's the impedance resistance concept. By using that concept and measuring the impedance, the ICD field has diagnostics which come as OptiVol in some of the devices as a marker of volume overload. There's problem with sensitivity, so it hasn't caught up. If you look at it, the sensitivity is about 40% here in some trials. And then just recently, the multi-sense study got published where using a plethora of markers, the sensitivity seems to have gone up. But the point is that there's a lot of patients who don't qualify for CardioMEMS. There's a lot of patients who have ICD. The device diagnostics are all there. I don't think it's been effectively used as much. And essentially, the device diagnostic need to be ported back along with hemodynamic monitoring, not just for early identification, but there's an opportunity for education, risk factor control, up-titration of medications, porting it into the social media. There's a lot that can happen. If we interest Google or Apple, probably it'll take a great step forward. But there is an opportunity for remote monitoring. There are technologies that are coming out, many more technologies that are coming out. And I think as much as we don't want to be monitored, patients actually like that because they feel safe about it. Thank you.
Arvind, as always, thanks for a good talk. We do have time for a few questions.
You alluded to this point a little bit, but what exactly are the interventions that made the difference? Because typically in clinically, most often you just maximize the medications as much as the blood pressure tolerated. That's kind of pretty much the goal of many times. We kind of optimize the medications on heart failure therapy. So is it just the diuretics? Did someone specifically looked into that? What actual intervention that made a difference?
You mean in the CardioMEMS?
In CardioMEMS, sorry.
Yes, so in the CardioMEMS trial, there was a kind of a mixed focus on both diuretic and afterload reduction. But if you look at the data, a good percentage of patients had isosorbide and hydralazine also increased. In our protocol, we actually add a blood pressure into the monitoring. So I tell all my patients to check their blood pressure around the time of transmitting their CardioMEMS. So if their pressures are high, then when the nurse calls them, they tell what the blood pressure is. Because if their blood pressure is 180 over 100, I'm not going to diurese them. I'll go up on the afterload reduction. So it's kind of a combination of both. The hope is the technology will evolve where all those information will come into one port so you can look at the blood pressure, look at the pressures, and adjust accordingly.
How big is your CardioMEMS devices? Is this the pocket size, or patient can travel with this, or patient can go out of state with that monitor?
Yeah, so the monitoring right now is a carry-on. It was a check-in luggage before, now it's a carry-on. But you can travel with it. We've had a patient recently who actually got it done and transmits from Guatemala. So it's quite portable now, and hopefully as technology evolves, it can get smaller. But we tell patients if they can to travel with it. And as a medical device, I'm told it is free. They're not going to charge when you check it in, even if you check it in. Yes, there's one more question. The pulmonary artery. Pulmonary artery.
I know they're already on blood thinners and all that good stuff, but if it fails, is it easily retractable?
It's a good question. I think the failure rate was extremely minimal. Actually, there was no need for retraction in any of the studies. We've had one patient where it got damped, so we're not using it as much. But the safety profile is very good. So in the whole trial, in the real-world experience, there hasn't been any that have been retracted, except there was a recent case report in a radiology journal where they said they retracted it out because they thought it was infected. But otherwise, we have patients who were a part of the trial who got transplanted or immunosuppressed. We just leave it in. It doesn't matter much at all. It kind of gets endothelialized just like a stent, and it just gets incorporated into the wall. That's a good point. I think I skipped through that. Aspirin and Plavix for a month, and then lifetime aspirin after that. If you're on Coumadin or Noax, then you don't need any of those. Yes, ma'am.
For the heart failure patient going to the operating room, is there any way to utilize the CardioMEMS for real-time observation of their their sogginess of their lungs, so to speak? And also, you talked about the thoracic impedance. Is any AICD able to calculate that, or is it only the newer devices?
So the first question, I think all hemodynamic enthusiasts are very excited about the CardioMEMS to use in various settings. It's not a continuous monitoring though. So in the OR, if you need it, there is, in the hospital, there's a system that you have to take in and then interrogate it. So it has to send a pulse and then it retrieves the pressures at this stage. So there's a little bit of logistic challenges to do it as a continuous monitoring. The impedance are depending on the device. So the older device don't have it, and depending also on the company, each metrics are different. They're all based on the same concept, but one is called OptiVol, the other is MultiSense. I think there's an opportunity which we are trying to do to organize them into pockets and then port it into our heart failure clinic, but it's not universal.
Session. Dr. Felker, CardioMEMS at Duke. Do you guys, haven't used it yet? Dr. Nir Uriel, who I'll have the privilege to introduce later, at University of Chicago, are you guys using CardioMEMS yet?
And yes, in Chicago, we love the CardioMEMS. We have a lot of challenges with it, and it's interesting to see. So the data that you presented and the real-world data are even stronger, and we all try to implement it on patient care. The problem that we are facing in the Illinois state, it's actually the private insurance blocked it. So both Blue Cross, Blue Shield, all of those insurance. So the only patient currently in the University of Chicago that have a CardioMEMS device are the Medicare patient that is approved. In Houston, do you have a better system that you succeed in putting those patients in?
No, it's actually the other way around, because in Houston and some parts of Louisiana, the local contract for Medicare is Novartis. And that local contractor basically said they're not paying. So in Houston, we don't get paid for Medicare patients. They can go to like Dallas and get it done over there. So they're trying to overrule that. Private insurances, most of them are paying in Houston.
I have to say, this is a challenge because Dr. Felker just showed an update about heart failure, and we are showing here something that is a game changer in the field of heart failure, whoever taking care of those patients. I see what's going on with the challenging patient from my iPhone. I'm going to, as you said, Marilyn.net, and we can really avoid hospitalization. But the noise that you said about mortality is actually becoming very, very strong in the real life. As you know, there is going to be in March 9, the late breaker of the CardioMEMS effect on mortality in real life in ACC. So this is going to be presented in the common ACC.
Good.